Welcome, everyone. I'm Stacy Heilman. I'm the Associate Vice Chair for Research in the Department of Pediatrics at Children's Healthcare of Atlanta, and I am also serving as the Interim Director for CCNR, which is our Children's Center for Neuroscience Research. Really delighted to welcome you all to today's seminar, and I'm going to turn the reins over to the distinguished Dr. Andrew Reisner, who is a neurosurgeon at Children's and also is the leader of our traumatic brain injury research program. Dr. Reisner?
Thank you, Stacy. First of all, good morning to everybody here. And I'd like to just start off with a quick thank you to you, Stacy, and of course you, Barbara, for organizing this meeting. With that, I'd just like to say that it is with great pleasure, and I'd like to give a warm welcome to Antonio Belli, a professor of trauma neurosurgery at the University of Birmingham and a practicing neurosurgeon at the Queen Elizabeth Hospital in Birmingham, United Kingdom. Let me get rid of my phone. There we go. Professor Belli graduated from Tor Vergata University in Rome with a degree in medicine and surgery and completed a doctoral degree on brain ischemia and reperfusion. Between 2001 and 2003, he was a research fellow in neuro monitoring at the Institute of Neurology in London. Professor Belli has trained at very prestigious centers in neurology and neurosurgery in the United Kingdom, and these include King's College Hospital, the Atkinson Morley's Hospital, National Hospital for Neurology and Neurosurgery, and just around the corner from there, the Great Ormond Street Hospital, as well as the Royal Free Hospital, and now where he is in Birmingham. Birmingham, as those of you who do neurology and neurosurgery know, is an absolute center of excellence for trauma, neurotrauma, thanks to Dr. Belli, and as well as pediatric neurosurgery, thanks to his colleagues, Dr. Saldansky and his predecessor, Tony Hockley. You know, folks, I've worked in South Africa and the United States, and I can tell you that regardless of which side of the equator you are on, all those places I mentioned are certainly the meccas of neuroscience, and we're just honored to have you here, Tony. Professor Belli is the chief investigator of several national and international clinical studies. He is the National Institute of Health Research Senior Investigator and the Director of NIHR Surgical Reconstruction and Microbiology Research Center, which is the only publicly funded trauma research center in the United Kingdom. If that's not enough, Professor Belli has a special interest in sports concussion, and he is a guidance author and advisor to the England's Premier League, the Rugby Football Union, the Football Association, and the Cricket Board. He has published extensively, and I went onto the University of Birmingham research portal last night, and honestly, Tony, you're putting us all to shame. There are already 8 peer-reviewed articles just this year alone, and not only is the quantity there, but the quality as well. He published what I'm sure will be a seminal article in the New England Journal of Medicine in December of last year. What's not cited in Tony's biography, and really should be, and I'd like to correct it here, is his extraordinary literary skills. For example, the name Scrum Study is pure genius. For those few of us that don't know what Scrum stands for, it's a mnemonic which stands for the study of concussion in rugby union through microRNAs, hence the word Scrum. And so, Tony, I just want to know how impressed we all are at your literary skills, and it comes as no surprise to anybody in Atlanta that you live relatively close to and drink the same waters as those who live in Shakespeare's Stratford-upon-Avon. It's quite amazing. But before I hand over to you, Tony, I'd like to remind this audience that Professor Belli will wrap up his talk at noon, our time, Eastern Standard Time. So that would be about 5 p.m. Greenwich Mean Time where he is. In other words, opening time for many of the local pubs. So please, although he's been kind enough to indulge us with a few questions, we'll be very considerate of your time, as this is undoubtedly a long-awaited time after yet another long working week for you. So with that, Tony, over to you.
Okay, thank you very much, Andrew. That's a really, really kind introduction, and absolutely. I think you deserve the title of the national bard for your words. Not me. And actually, I have to confess, the title Scrum came from one of my postdocs, and I think I was just saying to somebody today, you're really only as good as your team. So I'm actually really lucky that I'm surrounded by some very bright people who make up for my inadequacy in many areas. So I think, it's fantastic to speak to all of you today. And I think it's a great honor to, thoroughly to join, friends and colleagues and people I haven't met yet over the Atlantic. I think it's fantastic to have received this invitation. So as Andrew said, I mean, my interest is traumatic brain injury, primarily, both clinically and academically, which is actually, in a way, years ago, no one would touch traumatic brain injury with the end of a barge pole, and I think it's now become very topical. And I probably just happened to be in the right place at the right time, I guess, with a lot of the things that I'm going to talk to you about, including sport concussion, which is obviously is a very interesting topic right now, and is very prominent in a number of different areas. And so I think traumatic brain injury in general is something that fascinates me. And it is the leading cause of death and disability under the age of 45. It is projected to have become, by last year, effectively, we don't have the figures yet, the third largest cause of global disease burden worldwide. It disproportionately accounts for, sort of large proportion of trauma. And in the UK is a population of, nearly 70 million now. So every year there are 1.4 million people admitted to A&E, so accident and emergency, so the emergency room, with some kind of form of head injury in the UK. That's a huge number. I know, so it's not the biggest cause of presentation, but still, 1.4 million is sizable for a country like the UK. But what is really alarming it's a disproportionate cause of death and disability. So it's actually like for like. I think if you have head trauma, you're more likely to do badly. And obviously, I know that Andrew's interest is obviously pediatric neurosurgery, and actually it is a big concern for the pediatric population, for the young adults in particular, but certainly it's being the leading cause of death in children and young adults. And I would say in the UK, in many other Western countries, we're actually seeing a sharp rise in the elderly right now. So what was before a sort of condition of young males has now become sort of a condition that affects young males and both genders in later life. And actually, just in the last 10 years, we've seen such a sharp rise in elderly trauma, sort of neurotrauma in particular. Sort of just to give you an example, in my hospital, which is a sort of major trauma center, 10 years ago, the proportion of people over the age of 65 with major trauma admitted to hospital was 2.5%, and it's now 25%, in just over 10 years. So like a quarter of our major trauma is elderly. And if something that's really close to my heart is actually how much of this disproportionate affects people living in low to middle income countries. 90% of the global burden of trauma and TBI happens in poorly resourced countries. And this is a huge issue, because not only is that a cause of poor health, but it's also a big cause of destitution and poverty. Taking particularly the breadwinner out of the equation means the whole family being thrown into destitution and poverty. And so obviously trauma primarily affects people of working age, and if you're working, if you travel to work, you're disproportionately more likely to suffer head trauma. So this is a huge issue. There's the talk will focus very much on sport concussion, but which is often concussion is used mutually with the term mild TBI, mild traumatic brain injury, but the term mild in the context of TBI doesn't really mean mild for a number of different reasons. I think there's it's a misconception. If you have a mild TBI, most people, and including doctors, think you're going to be all right, and that's not the case. And this is it's now sort of the study that you see on the slide is this relatively old study, but it's been replicated by other studies in a number of different settings. This was from the Glasgow population, where they actually followed up people with mild TBI for a year. And actually, what is really staggering about this study is actually that the mortality, even among the mild TBI group, was close to 10% a year later. So it's not mild, doesn't mean mild if you're 10% likely to die. And actually, only less than half the people that had mild TBI actually returned to a normal outcome after a year. So, the majority had moderate disability or severe disability. People, when the study came out, oh, this is Glasgow. Now, Glasgow is a part of the UK where people are not particularly healthy, and Andrew is very familiar with the UK geography and demographics. I think that's a part of Scotland that is not particularly healthy. And people, this is an outlier. But actually, then the study has been replicated in many different settings, and the findings that have been confirmed. I mean, mild doesn't really mean mild. Even if you have mild TBI, you're likely to suffer premature death and obviously associated morbidity. Clearly, there is a distinction to be made, because the vast majority, what we mean by mild is often in neurosurgery is people that have had, sort of a Glasgow coma score, after an injury between 13 and 15, whereas in sport, it's very rare that you see somebody with a presentation of less than 15. So we say people that introduces concepts of minor head injury as opposed to mild. But still, this is the point is worth making, that even mild means you're likely to encounter disability, even for what is considered a relatively trivial injury by many. But the problem is that we're going to sort of address today is really what happens in sports. And this is an increasing concern for parents, for coaches, for children, for adults that play sports. I mean, sports accounts for about 10% of all cases of traumatic brain injury. Depends slightly on where you live in the world and how the figures are collected. But what is alarming about sport is actually that is this what seems to be a relentless increase in the number of injuries reported year on year. I think it's 6-7% year on year increase in the number of sport concussion. And this is just not only in sports, but also in the military context. The center that I direct is funded by the Ministry of Defence in the UK, as well as the Department of Health. So we got a split model. So but the figures are the same similar for UK and US military. But what's driving this increase is probably a number of factors. Many people propose that actually there's an increase in physicality of the sport. For example, one of the commonest sports in the UK and in South Africa is rugby, and the average rugby player has gone up a stone, which is about 7 kilos in the last 10 years. So the players are getting bigger. They're also getting faster. They're also spending more time in the gym than actually they spend on a rugby pitch training. I mean, there's more emphasis now on physicality in many sports. Clearly, you need to be talented, you need to have the right genes probably, but clearly, unless you spend 7 hours, 8 hours in the gym, you're not going to make it. So the players are getting faster, they're getting bigger. And that's probably what's behind some of these number of concussions. But there's also increasing awareness, which is actually a good thing. So people are more inclined to report concussion now than they were just a few years ago. And a lot of this has also been driven by litigation, clearly. I mean, obviously, all of you will be familiar with the lawsuits against the NFL in North America, which was actually made on the basis, not that, American football is dangerous, but more on the basis that the NFL had information that they actually concealed from the players in regard to the danger. So yeah, obviously everybody accepts, this is a physical sport. You're you're going to get hurt. But what actually was less acceptable is actually to dismiss some of the information that had in regard to the risks of playing American football that were not fully disclosed to players. So that's, and obviously, the initial award was for close to $700 million, which sounds like a large figure, but I hear that's what the NFL makes every weekend, so it's probably not that big for them. but actually, it's open-ended, and actually, there's more litigation. Actually, there's a litigation coming to our shores as well. So there, just about a couple of months ago, there was a case brought by retired rugby players against World Rugby and England's Rugby Football Union. Again, on the same basis that not enough care was taken to protect rugby players, some of whom have actually gone on to develop symptoms consistent with dementia at a young age. And I don't know, many of you have actually seen the film Concussion with Will Smith. It's actually a decent film, I think, which is a story of Benito Malo, who's the neuropathologist who first described changes in American football players that were consistent with chronic traumatic encephalopathy that was previously only seen in boxers, and the story about him, sort of taking the NFL on, and obviously with, in a way, the NFL trying to stop him in many different ways. So it's a good film if you haven't had a chance to see it. So where is all of this leading? This is leading to the fact, obviously, there is increasing awareness. I mean, doesn't mean that the problem is now solved, and probably not. I'm just going to give you an example. This is an example from soccer, which is the most popular sport in this part of the world, and in many other parts of the world. And this is a Champions League quarterfinal just from a couple of years ago. So the event is probably watched by more than 1 billion people worldwide. So this is Vertonghen, which is who's a Tottenham player, and he collided with an Ajax player in the quarterfinal. It looked like a head injury to most people, including the ref, who stopped the game, asked for Vertonghen to be assessed. He was assessed and then allowed to return. He looks all right. Just a few seconds later, he has to be helped off the pitch with what looked like to the world as a concussion. But the official report from the club was that he fainted, only for Vertonghen to disclose a year later, yes, I had a concussion very clearly. I was allowed to play, and I'm still not feeling right. A year on, why did that happen? Anyway, so this was a couple of years ago. So is the world changing? Okay, well, is the world changing? I don't know. This is UEFA. UEFA are currently running for those of you who are into soccer, there's a big competition in Europe now called the Euro 2020. The time you're not being cryogenically preserved. It's just because the 2020 didn't happen in football, so they're now playing 2021. But it's a very big event. It's the Euros. It's a very big event, and finally UEFA, sort of the European football organization, issued a statement, issued a charter. This says you can't quite see it. I don't think 12th of June. This year, so about less than a week ago. So the concussion charter, 24 doctors managing the nations participating in the Euros have come together and under the aegis of UEFA to adopt this charter about managing sport concussion, not allowing players to return, and big publicity around this event. Less than a week later, 16th of June, UEFA summons the French doctors because one of the players, who was, very, very happy to admit he was concussed for 15 seconds on the pitch with clear loss of consciousness, allowed to return and playing to finish the game. So the ink wasn't even dry on the statement they issued sort of just 4 days before. To say this is going to be sorted now, no more nonsense, and then this happens. And clearly the doctors are under a lot of pressure when in that scenario. It's a big competition, the world is watching, but it's a big competition, and why does this thing still happen is a bit of a mystery. But when we talk about concerns about spread concussion, we probably talk about different things that are often conflated, but they're very different. One thing is that, the doctor on the pitch side will be very much preoccupied with the early damage of concussion. What happens to players that there's been concussed? Is there the possibility of intracranial bleeding or a skull fracture or anything that sort of requires immediate attention? But then there are other issues. For example, what might happen to a player that sort of is allowed to continue the game or is allowed to return before recovery has occurred, which is something called the second impact syndrome, and that is the big issue about long-term effects, repeated concussions, and neurodegeneration. And so when we talk about the early damage, something that probably worth introducing now. So the mechanisms of early damage take many different forms. The direct impact will cause shock waves that propagate through the brain. The brain is made of sort of different parts of different densities. So the gray matter is different from the white matter is different from the TSF. And where you have shock waves that propagate through a medium of different densities, you will have energy that gets released at the interface. So that can cause damage to neurons. But what we are particularly worried about are the rotational forces that come into play when you have a concussion. So the rotational forces are something that you cannot mitigate against by wearing, head protection, for example. And this is one of the biggest challenges that we have. In fact, the head protection could potentially make things worse in a number of different ways, including risk compensation, a false sense of security, or in some sports even, weaponizing the head to inflict more damage. So this is the issues that we are worried about. But as I say, this takes many different forms. One thing that's actually worth stressing is actually serious injuries in sports. That the catastrophic injuries are actually, fortunately, very rare. Otherwise, very few of us would probably let our children play sports. But they obviously. The benefits of sports are really always need to be emphasized in many different contexts. This is not like a scaremongering story, and I really hate doing that, and I've tried very much not to do that. Since there are many different benefits of sport, which probably far outweigh many of the risks. But that doesn't mean we shouldn't try to reduce risk wherever possible. But just to emphasize, catastrophic injuries are fortunately very, very uncommon. So to a large extent, it's probably fair to say that there's a lot that we do not understand about concussion, the mechanisms of concussion, and it's important to state this. So on a very basic level, what happens if you simply stretch or strain an axon, you get depolarization, you get an electrochemical discharge, which then leads to the release of neurotransmitters from the synaptic end. And this is probably what is enough to trigger a brief impairment of consciousness, not necessarily loss of consciousness, in a brief period or disorientation or amnesia or stumbling that we often see on a football pitch, on a rugby pitch, or on a soccer pitch. So it's almost very much an electrochemical event, which probably leaves very little in the way of an enduring trace that we can pick out with any test. But that's not it, because on a sort of intracellular level, subcellular level, that could be associated with some damage which is not visible on the outside. And so, for example, the structures that are particularly vulnerable are microtubules, that sort of this cabling that inside the cells that enable axonal transport, the transport of mitochondria, microvesicle from the cell body to the synaptic end. And these are sort of very fine structures that get easily damaged if the axon is strained, for example, inside the cell. What happens if you do that? I mean, the microtubules is what will really enable axonal transport. If there's a heavy traffic of mitochondria that travel up and down the cells and microvesicles, and when the axon is strained, everything grinds to a halt, and it grinds to a halt really, really quickly, which means the axonal transport ceases almost immediately. And then you get inability of the cell to maintain energy levels, to release, neurotransmitters, to send signals from the from the cell body to the synaptic end. And that's not all of it, because what happens is the microtubules are fastened together by a protein that many of you will be familiar with called the tau protein. And the protein is what's been implicated in much of the pathology of CTE, chronic traumatic encephalopathy. So tau is an intracellular protein that gets released extracellularly when you have this kind of damage, and it behaves a little bit like prion disease. So tau that is released outside the cells causes the aggregation of tau from other sources, and it causes macroaggregates that then cause inflammation. So they just then you get a migration of inflammatory cells towards the aggregates of tau that can ultimately lead to chronic neuroinflammation and neuronal death. And actually, so these are inflammatory cells migrating to aggregates of tau that you can see there. And how long does this last? It can last for a very long time. This is a study from Imperial done with PET scanning. And this is from after a single mild traumatic brain injury. And this is the follow-up is up to 16 years after that initial event. And actually, you can see that in certain areas of the brain, for example, the thalamus, you can see signs of neuroinflammation that is persistent, probably in a latent state, in a dormant state, but it's there even 16 years after the initial event. So it seems that kind of that initial mild TBI is enough to prime the brain for a very long time. And obviously, if you then have further insult, that sort of inflammatory load will go up and up and up with a lower threshold. But when we come to the other issue that I was talking about is the second impact syndrome, which happens when the brain hasn't fully recovered from an injury, but then it gets hit a second time. It's rare, fortunately, because it's often fatal, and it's very common. It's more common in children and adolescents, actually less common in adults, but it's a particular problem for the young brain. Sorry, I don't know what's happened there. Yeah. So sorry, just start again. So the guy that you see in this picture is was unfortunately a young rugby player in Northern Ireland who was playing at his level, obviously in a competitive game. At the age of 14, he got hit twice, got concussed twice in the first half of the game, was assessed, returned to play, got concussed a third time in the second half, and he didn't wake up following that. And this has made legal history in the UK because it's the first time the coroner recorded a death by second impact syndrome in the UK. So recognized officially the existence of this pathology. And his father's become, sort of very active campaigner for safety in concussion, which, at least something good has come out of it. So we don't know what causes it, but we know that it is possibly many different mechanisms, but we know that ultimately results in malignant brain swelling, which is disproportionate to the severity of the second impact. And we're trying to study in animals, we're trying to study in humans, and actually one way we worked out we could possibly follow it up years ago was by looking at not so much ATP, because there's an energy deficit in the brain, but something that is a marker of mitochondrial function in the brain, which is something called NAA, N-acetyl aspartate. It's a compound that's almost exclusively found in neuronal mitochondria, and it correlates with the ATP production. And what we found is that NAA decreases after the first impacts, but if you hit the brain again, ATP and NAA decrease following the second impacts. And actually, the time the brain is most vulnerable is actually day 3 in rats, anyway. Not day 1. Obviously, day 1 isn't good, but actually there is a window of vulnerability that tends to last for several days. And the timing where you think the brain should have recovered may not necessarily be what you think it is. To say that the most dangerous time, at least or in this particular experiment, was actually day 3. But the good thing about NIA is actually we can also measure it with MR spectroscopy, so you can actually look at it in humans as well. And this was a study done in professional soccer players, where we could see that you can measure NIA, and NIA takes a while to recover in soccer players that have had a concussion. But if you've had 2 concussions, it takes even longer to recover. This is in a way supports the notion that if you have a double concussion, you're metabolically at least in trouble from mitochondrial point of view. This is a study we would not be able to replicate now, because the rules now say that actually if you've had a second concussion, if you've had a concussion, in theory, you shouldn't get a second one because you should be stopped from playing for a while. So at least we know that the players wouldn't necessarily come forward admitting they've had a second concussion. So it would be virtually impossible to do now. But nonetheless, I think that's it provides a bit of a mechanistic substrate for the theory that there's mitochondrial impairment that possibly leads to the second impact syndrome. But what is actually probably on everybody's mind right now is the issue of neurodegeneration. So what I'm putting out there, you have many examples in North America, and there's obviously you'll be familiar with it, with the Boston Brain Bank and Anne McKee's work on deceased American football players and obviously soldiers and other sports as well. But the case, again, it's made legal history in the UK, is the case of Jeff Astle. He was a football player, a soccer player, played for one of the teams nearby called WBA, West Bromwich Albion. I don't know if Andrew's familiar with WBA. He knows Britain much better than I do, but basically he was famous for his heading skills, and then he died of dementia at age 54. So yeah, young age for dementia. And then when the brain was examined, he had evidence of CTE everywhere. And again, the coroner took notice of that, and he recorded a death by industrial disease, which means that he made a connection between him playing football and his death of dementia. Again, this made legal history in the UK, and since his post-mortem, more cases have been found in the UK linking playing football and possibly heading the ball with the risk of neurodegeneration. But this remains a very controversial topic, I have to say. There's certainly evidence from the epidemiology studies. There's certainly evidence from animal studies, and one of the studies I found most interesting is from a group in Milan who found that actually that if you hit mice and repeatedly, they develop a tauopathy, which is the pathological substrate of CTE. Not only that, but then the tau seems to spread from one region to the brain to other regions of the brain, like Prions disease, as I said before. But it can also infect, in a way, other brains. If you take this tau from an affected mouse and you put the biopsy, put the tissue in another mouse, the second mouse will also develop a tauopathy, which is a little bit dangerous if you think about it. I don't want to go into that, but obviously we're all really concerned about Prions disease in neurosurgery at the moment. But if this is true, we probably need to be concerned about tau as well. But that's probably for another day. There is a counter argument to that in fact the epidemiological evidence is still rather limited. There's selection bias in many of the studies, the human studies, in that the people that have donated the brain to the brain bank have antemortem symptoms of dementia in large numbers. The reason why they went to donate the brain was because they were concerned about the brain health, or the relatives were concerned about the brain health before death. And also, we don't really know what explains the pathology. Is it just the concussions, or other factors like lifestyle, premorbid factors, drugs, performance-enhancing drugs? weight gain, which is not uncommon in for example, in American football players or rugby players. Once they stop playing, studies have suggested once you start correcting for weight gain and sleep apnea, these effects disappear. For example, there was a very interesting study published last week because one of the is not just dementia, it's actually things like motor neuron disease. That is quite common in retired athletes from certain sports. And it seems that there's a big correlation between a certain level of exercise, which exceeds what most of us would do, and goes beyond perhaps that sweet spot. So, that actually correlates with a higher incidence of motor neuron disease, just over exercising maybe. In genetically predisposed people, maybe enough to trigger certainly ALS, motor neuron disease. Also, we need to consider the benefit of sport. And one of the most protective factors that we know of against dementia is actually having an active life, and we certainly recommend it to our patients. There is some evidence. I think the study that again made the headlines in the UK is a study from the Glasgow group that showed that actually there's a higher rate of neurodegenerative disease in retired professional Scottish soccer players. So a large cohort over nearly 8,000 people, nearly 8,000 footballers. And actually, one thing to say is actually the mortality was actually lower in footballers, and actually on average you lived about 3 years longer than the people matched for year of birth and postcodes, sort of zip codes. But if you look at people, soccer players were less likely to die of ischemic heart disease or lung cancer. But once you adjusted for competing hazards, they were nearly 3.5 times more likely to die of neurodegenerative disease in the study. So on the basis of that, I think then the Scottish football authorities banned heading in young players, so under the age of 10, and this has been followed by similar measures in England and Wales. So I think just people don't know what caused this increase, but as a precaution, I think that they decided that heading the ball was actually to be banned in young players. That connection has not been made, but obviously it seems sensible to do something along those lines. And I think you can make up your mind whether this was the right strategy or not, but I think it's something that the authorities felt had to be done. One thing that I have to point out in all of this is actually, I'm not on either side of the fence, but for example, there are other studies that suggest that, particularly in severe TBI, that there is a risk of dementia, but that happens in predisposed individuals anyway. So the risk doesn't increase overall. But if you're going to get dementia, you're probably going to get 2-3 years younger. So overall, the incidence is the same, but it just brings the onset forward by 2-3 years if you have a severe TBI. And other studies in retired athletes haven't confirmed those findings. There is no evidence if you've played professional sports, if you've had a severe TBI, once you get dementia, you dement more quickly, or that your progression is any different. So it may be happening at an earlier age, but it doesn't seem to be progressing at a higher rate if you play professional sports. What is also puzzling is actually that we still don't know what causes dementia, many forms of dementia, and we know what's associated with dementia. So we're still missing the link between the damage that you get in TBI and what actually triggers the neurobiology of dementia. So what is it? And if there is one mechanism, is it plausible that if you get the same cause that what actually leads to Alzheimer's disease, Lewy body dementia, or vascular dementia? In a way, does seem a little bit implausible that there's a common link that would trigger all these different forms of dementia by the same mechanism, which actually take very different forms. But one thing that's probably plausible is actually if you have multiple concussion, that reduces your cognitive reserve. Therefore, you may actually display effects of dementia phenotypically at a younger age, simply because your cognitive reserve has been reduced. But and is it just professional athletes? That's a very important point. You know, that's does it apply to everyone who plays sport, or is it just the professionals? Because obviously the professionals are not like the rest of us in many different ways. And they, for example, my son plays football, but you wouldn't have the ball in training 20, 30 times a day. You know, to say it's something he doesn't do. He's 16, so you know they're lucky enough to see a header every game at his age, and certainly they don't do a lot of that in training. So is there an optimum? Is there a threshold for risk? We don't know. What are the effects of genetic factors, subconcussive injuries? That still needs to be determined. But all of this is really leads on to how we manage concussion, what we can do differently to keep players safe. Every sports authority will have a set of guidance, and it looks vaguely the same but vaguely different for each sport in different parts of the world. Loosely, they're all based on a consensus conference that happens every 4 years. Last year, again, 2020 didn't happen. But it was meant to be in Paris last year, but it didn't take place. But it was actually based on 11 hours. Obviously, the less are very much, but the first 2 points of that are how we manage concussion. First of all, it's really to recognize it. So it all starts with recognizing when a concussion occurs, and then following that is to remove the player. So unless you're able to spot when a concussion occurs, either during the match or after the match, nothing else matters, because you're not going to be able to keep that player safe. And if you look at what the symptoms of concussion are, I think the list is very long. But if you look at that, headache, pressure in the head, or difficulty concentrating, remember, they all seem very obvious, but they're also not very specific. Players actually play a match competitively. Many of the symptoms could be due to fatigue or much stress, lack of sleep, whatever. So it's very difficult for a doctor on the sideline to be conclusive about any of these symptoms of concussion. And then once you've recognized the concussion has occurred, then you move on to the other R's, which rest, rehabilitation, refer, recover, and then return to sport. So each authority will issue something that looks a little bit like this. So what you do is initially it's a brief period of rest. Prolonged rest is no longer recommended. So 1 or 2 days of absolute rest, but then you need to introduce some activity, which is initially limited by symptoms, and then light aerobic exercise, and then sport-specific exercise, and then non-contact training, and then full practice. In a professional sports setting, this can take as short as 6 days, 6-7 days, which allows a player to return for the following weekend usually. But in a non-enhanced care setting, in younger players, it can take 21 to 23 days. So obviously it depends on who's following you up and how old you are. So what are the risks if we don't spot a diagnosis? First of all, you may actually miss out on targeted treatment. So for many of the manifestations of concussions, we do have things that we can do. It's not pointless to diagnose concussion, because there are many targeted treatments that we can implement. You're also going to expose the player to the risk of repeated concussion, where you may get occasionally, fortunately very rarely, the second impact syndrome, but more likely a more severe presentation, more likely to develop chronic headaches, a chronic cognitive decline. There's also evidence that players that play with symptoms actually take longer to recover, and they don't perform well. So they let themselves down, they let the team down. They're also more likely to suffer other injuries, including musculoskeletal injuries. And this is a study from rugby showing that if you have suffered a concussion, you remain more likely to suffer musculoskeletal injuries than players that just suffered musculoskeletal injuries in the first place. And the same happens in soccer. So you're 50% more likely to have a musculoskeletal injury, possibly because of impaired reaction times, possibly because of reduced visual spatial awareness, maybe other factors. So if we have to rely on diagnostic tools as they currently are, well, how good are they? Well, concussion is one of the most difficult diagnoses to make. We lack, objective biomarkers. It's single event, but not a single pathology. It can be very subtle and easy to miss. It often evolves over hours a day. So a player can sometimes return and play well during the same match, but then in the evening they'll get a headache or symptoms of concussion on the following day. So it's something that could be quite insidious because it doesn't necessarily manifest itself immediately. And the current tools have limited specificity of sensitivity. Whatever tools we use, there are some limitations. We're going to miss a number of players. And just want to give you an example, because this is, and again, an example from rugby. And I don't know how many of you follow rugby, but this is possibly one of the most famous players in rugby. Somebody called George North, plays for Wales. And this is, rugby is actually very well organized in the UK. It's one of the sports where you have video replays, you have professionalized assessments, you get assessment different time points. So George North is probably one of the most famous players. He's also famous for the number of concussions that he suffered, and he's always in the media for that. So, if you look at it, there's a dent on the pitch where he lands. He was assessed according to World Rugby protocols. It looks like he's lost muscle tone immediately after the event, and he looks unconscious for a period of time. But he was assessed according to the protocol. The player the doctor didn't have the full footage, so he was allowed to return during the same match, and there was huge furor in the media about this case, and so how it was managed. Just to say that, despite highly trained doctors, very robust procedures in theory, you can still miss a sort of glaringly obvious concussion. And this is in particular if you just rely on the current tools. And this is a study from World Rugby, and I say rugby is very advanced in terms of sort of diagnostic protocols. So the on-pitch assessment. I'm conscious of time, but the on-field assessment has very limited accuracy, unfortunately. So the player initially will be asked some certain question called the Maddox question. So who are you playing? Who did we play last week? What's the score now? What was the score last week? Which city are we in? And if you just do that, you might as well flip a coin, because actually the area under the curve is 0.5%. So you really none the wisest. So if you break down the assessment, which is based on clinical signs and an immediate memory test, a recall test, and a balance test, for many of the things I say, you might as well flip a coin, because it's actually not very accurate. And it only really goes up if the doctor uses their experience to assess a player. So even comparing. If you can use the test in two different ways, you can compare to the player's baseline, so the sensitivity goes up, but the specificity comes down enormously, or normative data, and again, the sensitivity is slightly better, but the specificity is still down. Just to say, the current tools are not very good, even in the hands of professional doctors. So how can we improve that? So this is why we're really focusing on other tools to improve accuracy. And there's a lot of interest currently in concussion biomarkers, much in the same way as you would do for many other different areas of medicine, relying on objective tests. Obviously, it's not just biofluid biomarkers. People are looking at neurophysiology measurements, imaging, and so forth. So there's been a lot of interest in, particularly in protein biomarkers that may be coming from damaged neural structure, the glia, the neurons. They may be more or less specific, but there's particular interest in combining different biomarkers. It's a panel of biomarkers rather than individual biomarkers. And there's also interesting in novel biomarkers. And so there's been a bit of disappointment with protein biomarkers. But so we and other groups have been looking at different types of biomarkers altogether. For example, macroRNAs. And macroRNAs are little mRNA fragments that prescriptionally regulate the expression of genes. So what they do, they switch the activity of genes off or on, depending on what you need in response to an injury. And there's been a lot of interest in microRNAs, particularly in the field of oncology. So what microRNAs do is, as I say, they are secreted and packaged by cells in extracellular vesicles. They freely travel between cells, and then once they reach the target cells, they get internalized, and they exert the function in distal target tissues. And they say we have an abundance of microRNAs as messages in the bloodstream, but every tissue produces microRNAs, and every tissue has microRNA receptors. So this is what is interesting about microRNAs. So it's a new field, relatively new field of biology that's really gathering a lot of momentum. And just to say about the shortcomings of some of the protein biomarkers is that, from large studies, there's a lot of interest in particular in two proteins, GFAP and ECHL1, as the large studies and the CAR consortium in North America as well. But there are two issues with that. One is the timeliness. The timeliness so these proteins do appear in the bloodstream, but they do seem to appear with some delay. So, are they useful for this kind of the immediate assessment of concussion in a pre-hospital setting? So the timing may be slightly against that rapid assessment. But there's also the issue that once you have a patient who may have orthopedic injuries, for example, clearly they're not purely of intracranial derivation. There's extracranial contamination. So once you start having this kind of dirt injuries, their specificity goes down significantly. Also, this is a study that we did a few years ago in our group using a bioreactor. We have a stretch model of TBI using organotypic cell cultures. And actually, if you stretch cells, you can mimic what happens in a road traffic accident effectively. It's that kind of diffuse axonal injury. And obviously, so what works out is that I'm going to cut sort of the long story short, but what happens, what we worked out here, there's a release of GFAP and S100B and other compounds, but it seems to happen with some delay, but also the gene expression. So these are not just coming from damaged cells, but there's actually active gene expression of GFAP. So it's not purely from cell damage, like you get troponin, for example, from damaged myocardium, but there's actually gene expression that actually takes several hours. It's very quick in severe TBI, but in mild TBI, it can take a day or so to reach maximum gene expression. So just to say, this explains this kind of delayed sort of release of these compounds. So we've become interested in different types of compounds, for example, say microRNAs. And a few years ago, we did a study called the Golden Hour Study, where we were collecting samples from patients who had road traffic accidents. And what we could see is actually there was a very quick change in expression of microRNAs in the bloodstream. And in fact, we're very good at diagnosing, telling mild TBI patients for people who had severe TBI, for people that had extracranial trauma, with nearly 100% accuracy in that study. And these were samples that were taken before any kind of other intervention had taken place. So the first time a paramedic got to a patient at some hospital. But the problem is this is blood, and it's very difficult to do a study in blood in a sports setting. You just don't get the samples. It just takes a very long time to do the study. Players don't want to participate. So we became interested in saliva as well. And saliva is very interesting from this point of view, because saliva is absolutely packed with microRNAs. It's got more microRNAs than any other biofluid in the body. We produce 1 or 2 liters of saliva a day, and saliva has got many functions for the regulation of the gut, so the gut microbiome, as a disinfectant, and also possibly as a signaling biofluid as well. So we started off with a study in the clinic first, where we're looking at microRNAs in athletes that had concussion compared to normal individuals. We found that a few of these microRNAs had potential interest. So at this point we linked up with the Rugby Football Union in the UK to do a larger scale study looking at macroRNAs in saliva of professional rugby players. So this is a Scrum study that Andrew was alluding to. So we started in 2017. We collected the data over 2 seasons, and there's a publication in the British Journal of Sport Medicine that came out this year. So we collected samples pre-season, then at different time points. So during the match, immediately after the match, and then after 2 sleeps, which corresponds to HIA3, head injury assessment 3. We also collected samples from controls, that people that had musculoskeletal injuries, people that played the game but hadn't suffered any kind of injury at all. So we recruited over 1,000 players to this study. First, we did a sort of next generation sequencing exercise where we were completely agnostic to any previous results. So we just took groups of patients to see what macroRNAs were differentially expressed between groups, and that we started off with a huge list, and we'd narrow it down progressively by excluding macroRNAs that obviously we used the false discovery rate, but you've also looked at macroRNAs that were, for example, also expressed at baselines, or also expressed in players that, for example, just simply played the match. So we're not clearly, probably due to dehydration and match stress. So we narrowed the list down progressively. And then we also worked out that actually the combination of different macroRNAs was better than looking at macroRNAs individually. So imagine this as a piece of music playing. You can't really guess what music has been played from just one note. You need to listen, to the full notation. You need to listen to the full piece of music to understand. So this doesn't work particularly well if you look at the individual macroRNAs. So if you compare it to baselines, you've got thousands of macroRNAs that are differentially expressed after you played a match, irrespective of a concussion or not. If you then start excluding players who've been, say musculoskeletal injuries, the list goes down. But it's only when you really combine these in a panel that you get the true picture. Because imagine this is the acts in concert. So they just have to switch genes on or off in a programmed response way to modulate the response to injury. So when you combine it, we're classifying the combination of these macroRNAs was really good at predicting which players had suffered a concussion from the one who were assessed but then passed the test. There's always a risk of overfitting with this kind of exercise. So what we did is to develop the algorithm in one season and then blindly tested the following season. So we just said, well, okay, this is what we got this algorithm now, but does it actually hold true when we test players blindly, prospectively, the following season? And actually, what we worked out when we did this, the results were still very good. This combination of biomarkers was highly predictive of concussion in about 95% of the players. So the area under the curve was 94 to 96%. So we were obviously very pleased with this. So this went around the media. It was a big story that we obviously very pleased about. That I have to say, there's a lot of work that still needs to be done to confirm these results. I think we're doing various bits of work with various sports authorities now in rugby, football, in soccer, Olympic sports, and particularly we want to see whether the utility of the test in an elite sports setting, but also in community sports, where we think the biggest gain is probably going to be for community sports where currently there is no assessment available. It's often in the hands, of a parent or a coach, but there is no professional assessment. We tried to include women, but we didn't get to because the assessment not robust enough in female sports. I'm interested. I'm going to skip that. Right. So, a couple of questions that are really intriguing. So, how do the macroRNAs get to saliva? We know they're present in the bloodstream really quickly, and we think possibly there's what we may sort of call it, snooker ball effect. If they're present in the bloodstream almost immediately, can they just mobilize macroRNAs in target tissues like saliva really quickly? That's the possibility. Salivary glands are also innervated by the parasympathetic, by the vagus nerve. So potentially the vagus nerve has been implicated in a number of mechanisms linked with sport concussion and TBI in general. Is there something there? We just don't know. There's a lot of work that needs to be done. The other question, what do they actually do? What do we have them in saliva? So if we look at their targets, we see they do a number of different things from intracellular signaling to switching the body from a glucose metabolism to fatty acid metabolism. There are mechanisms of neuronal repair that we can see in salivary tissue even. This is to say it's an open question. I have to say there's some intriguing work that we're doing and other groups are doing. So what are the next steps? We are collecting more data. We want to refine the algorithm. We're certainly interested in younger players. We're definitely interested in women because they're often neglected. They're not included in many of the large studies, but clearly the recovery times are different between men and women. And this is something that really needs to be addressed quite urgently. We're also interested in the return to play. These have a prognostic value as much as a diagnostic value. I have to say, this is my final slide, that there are many other areas of research that we still need to address. I think, I'm very glad that the world seems to turn its attention to sport concussion in general, particularly to, the issue of neurodegeneration and risk factors, and there's work on biomarkers and neuroimaging. We in Birmingham, we have this sort of umbrella study called the RECO study on repetitive concussion, where we do biomarkers, we do advanced neuroimaging, we do neuroinference spectroscopy, we do vestibular studies or gait analysis. All of this is becoming phenomenally interesting, particularly if you look at the problem from a multimodal point of view. I strongly believe there isn't going to be one thing that gives you all the answers you need. You just have to look at it holistically and possibly in a multimodal way. So taking you through sort of run through of what we do in Birmingham, what the study's about. I have a huge number of collaborators, and I'm going to finish off by saying that I think this is, for me, is very exciting for a number of reasons, including the opportunities to collaborate with people across the globe. And I'm very excited to have linked up with Andrew and his group, because I'm not just saying it, but anyone who wants to come to Birmingham on a visit, we would be absolutely delighted to if you're showing an interest in our research, and just exchange ideas, exchange students, exchange opportunities to collaborate. I think there would make this a big success story for me personally. So thank you. Just as I'm losing my voice, thank you all for listening, and thank you again to Andrew and his colleagues for inviting me today.
Tony, thank you very much. This is Andrew. I don't know if you can hear me. That is just fascinating and incredibly innovative and inspirational to all of us here in Atlanta. I'm going to heed my own admonition and be respectful of your time, seeing that we passed opening time, and perhaps give my colleagues a chance to jump in and ask a question, any of those that have.
The pubs aren't open yet, so it's fine.
Oh, okay.
And I'm drinking water just in case you would doubt.
There we go.
Andrew, can I ask a question? This is
course.
Sumit.
Just jump right in, Sumit.
Hey, Dr. Belli, thank you for the talk. I looked at those heat maps of yours with the microRNA. Is there a particular gene signal you're getting, like certain apoptotic markers or genes which are upregulated or downregulated from the early microRNA data you're getting?
So if you look at the with those heat maps cluster, they seem to be focusing on cluster around mechanisms of neuronal repair. So there's all the intracellular signaling seem to, as I say, cluster around mechanisms of neural repair, which is obviously, it's nice to see. Also, one of my postdocs came to me a couple of days ago. This is obviously very preliminary, and she's done a lot of work looking at similarities between what we've seen in the study and neurodegenerative diseases. And actually, a lot of the signals that are in common are around the extracellular matrix. And so the deposition of beta amyloid and tau protein and the scavenging of these. So this is to say there are some mechanisms of neural repair, but possibly what's in common between the two is some mechanism that potentially may lead to neurodegeneration later on. And what was really interesting for me was also this switch between from glucose metabolism to fatty acid metabolism, which again, would fit in with the role of saliva in a way, telling the gut microbiome that an injury has occurred and we need to mobilize, our fat stores, because, from an evolutionary point of view, this seems to make sense. An animal that's been injured would probably have limited access to, the high glycemic index foods, and may have to use some of their own reserves. So I think this, it's a very interesting conversation and probably work in progress, I have to say. But focusing on neuronal repair is what seems to jump out.
Thank you. Would there be any interest for the group to look at the CSF and the markers, and especially beta amyloid, and also the any correlations with the saliva?
Very much. So
because there'll be good surrogate markers.
Very much. I think is where we're going to go next. I think we're trying to get some macroRNAs in the CSF and see how much overlap there is. And possibly we're going to get some brain tissue as well from, we got ethics now to use biopsies from people that undergo surgery for brain trauma. So we may be able to look at those correlations a little bit closer.
Thank you.
Thank you.
Hi, this is David Archer. Having played rugby for 15 years in the UK and had many concussions, I still have trouble remembering my own name. I'm presuming that this would be applicable to stroke as well, right? And, I work in sickle cell disease, and so we have a lot of kids who have silent infarcts all the way, during their lifetime.
Again, I think we are, you're ahead of the game. I think we're collecting samples from stroke, and I think there's we started this slightly behind the curve compared to concussion, but when in the UK. A little while ago, we just started, the hyperacute stroke service. So people, particularly with now that we can show that thrombectomy is highly effective. There's certainly a much greater incentive to have a rapid test for stroke. So we started recruiting stroke patients. There's also great interest in being able to differentiate between hemorrhagic and non-hemorrhagic stroke. So this is kind of the work we're doing now, is that earlier diagnosis of stroke and possibly better diagnosis of stroke as well, if we can do that with salivary macroRNAs. Absolutely.
Be really cool. Thank you.
Tony, if I could jump in and ask a quick question, coming from the pediatric and children's world, what is the minimum volume of saliva you need to run a decent next-gen sequence?
So very, very little, in fact. I think when we started doing the study, we started with 2 mils of saliva from players. Well, actually, some's minuscule, but actually really difficult to get because the players are dehydrated. Just to produce 2 mils of saliva can take 2-3 minutes. In fact, we had a special dispensation from World Rugby to extend the period of assessment from 10 to 30 minutes for that. What we do now, I don't know if you can see it, we use a mouth swab, which is very similar to what you use for COVID. So a mouth swab takes 10 seconds and it collects just the right amount of saliva. So it takes 10, 15 seconds just right on the floor of the mouth. And you only need about 400 nanoliters of saliva to get enough material.
And then do you store it? Do you freeze it straight away, Tony? Or so
the swabs are stable at room temperature for up to 8 weeks.
Wow.
And so it's really good because actually that means the clubs don't have to worry about, processing the samples, freezing them or whatever. They can keep them on a shelf for a little while. And then we go and collect them. And also means for community applications, makes it ideal. And then we would just use the extraction kits and then keep in the -84 hour. So by what's good is actually they stabilize at room temperature for a long period of time.
Great. And no preservative in those swabs, just a plain old swab.
There's an RNase inhibitor in the tube. So once the swab is inserted in the tube and the cap is screwed, the RNase inhibitor is activated, and that does the trick. It just stops the degradation of the RNA material.
Fantastic. Tony, I cannot thank you enough, and I'll just open up to anybody else. Any last minute questions for Professor Belli while we've got him online? If not, Tony, I know we will be in touch with all of us from different institutions here in Atlanta, and if you don't mind, we'll reach out to you with any questions going forward.
Absolutely. I hope this is just the beginning of of a journey together. And
Thank
again,
you.
I'm sorry I made everybody late. So again, thank you very much for this opportunity, and so that, I hope we can exchange visits.
Absolutely.
Yeah,
Absolutely.
on this call.
Absolutely. Thank you so much.
Thank you. Thank you very much.
You.
Have a good day.
Thanks, Stacey. Thank you, Barbara.